I'm here today to talk about a needs assessment that I conducted with my colleague Daniela Matthews-Trigg, who you can see on the slide, of people who are unsheltered, primarily in rural counties, and how that process ended up being way more messy than we anticipated, but we still made a lot of meaning out of it and got some meaningful results. So I took an incredibly long amount of time writing this speech because I didn't want to misrepresent any of the communities that we went into, any of the folks that we spoke with, the providers we spoke with, the work that we did, and exacerbate any negative stereotypes or stigma. I also didn't want to get roasted into oblivion by my peers or haters on the internet. So I just want to give you a quick perspective of what this presentation is not. This is not a guide map of how to conduct a needs assessment, and it's not traditional or generalizable research. It is an assessment for public health practice. This is not the full project results. We are still conducting the needs assessment and doing our analysis. It is definitely not encouragement to engage with your community if you haven't planned to do so. You really need an ethical plan to engage with your community and not do harm. And it's also not a justification for why you can't ever plan to engage with your community because it sounds complicated. And hopefully I don't make it sound complicated because I feel like it was fairly straightforward. You can see on the slide, that's the Lorax. It's also what my stepdaughter was for Halloween. But he speaks for the trees. And you can see the quote on the slide that says, nothing about us without us. That's a great harm reduction quote. We really need to be careful about who we are advocating for and planning programs for without their input and without them at the table. So what I actually am going to cover today is rapid evaluation in the real world. What is a rapid needs assessment, what our rapid needs assessment was, our plans, how we planned, how things didn't go according to plan, and what we learned. And then also how our rapid evaluation methods actually, I felt like, created change, not just identified the change needed. And then I'll leave you with some good resources. So what is a rapid needs assessment? The best example in recent memory that I could come up with is the COVID-19 pandemic, which was extremely unprecedented, scary, and horrible things were happening. And people were responding by hoarding toilet paper and also distracting themselves by making sourdough bread. And at the same time, behind the scenes, there were public health professionals which were doing really amazing work to, as best as they can, quickly, rapidly identify the needs in the community, create tailored messaging and interventions for things like containing the spread of the virus, disseminating supplies, and eventually increasing vaccine uptake. And then they had to do this all within the context of an evolving pandemic. So there are a lot of different flavors of rapid needs assessment. They all primarily involve flexible designs, participatory approaches, use multiple data sources, and generate quick action-oriented findings. And they're really just tailored towards the scope, the purpose, and the timeline of the project. So why did we start planning a rapid needs assessment? I came on during the tail end of a program called the Mobile Homelessness Response Demonstration Project, which was a very innovative project aimed at providing people who are unsheltered with services through a network of statewide providers, reaching them in the communities where they were at, and with the ultimate goal of helping them to obtain housing. So since it was the tail end of that project and we were starting to think about if we got the same level of funding, if we got increased funding, is that funding going to where the needs are the greatest? How are we defining those needs? Is it funding the right services? So we started to think about what data sources that we had available. And you can see on the screen, the little tags are where we had funded partners. In the middle of the screen was the results of the 2024 point in time count, which was the most available data that we had at the time. which is a kind of estimation, quantification of where people are throughout the state and the number of unsheltered people in each of those counties, which I will say is really reliant on volunteers. So these numbers are heavily influenced by the amount of people who can help in each community. And then finally, we have the 2024 pickup survey, which happened in tandem with the MHRP, where service providers asked people in the community, unsheltered people, questions related to their health needs, social service utilization, and the circumstances surrounding their homelessness. So you can see in these boxes, we've got huge swaths of the state where we're just missing information. We don't know things there. And we started to really think about if we're trying to reduce morbidity and mortality among unsheltered people, what don't we know about these areas? What does homelessness look like? How can we make a big impact with the capacity of our service providers? And what data sources are going to help us do that? So we looked at things like the CDC Social Vulnerability Index for transportation and housing. We looked at local data sources that showed us which health disparity conditions affect unsheltered people at a higher burden compared to the rest of the population in New Mexico, and tried to narrow down what it is that we don't know. And we selected 4 priority counties to conduct this needs assessment. Whoa, that came out really tiny. So sorry about that. So hopefully you all get the slides in the future and I will fix that. But we started with those 4 priority counties. We really wanted to better understand, in the words of people themselves, what are your top 3 greatest needs that would impact your health or quality of life? What are the barriers to getting those needs met? What service providers are you utilizing? And then if they mentioned specifically substance use or housing, we wanted more information on that. We also talked to providers in the community, and we were primarily coming into contact with unsheltered folks through a community windshield tour, driving through the communities because we wanted to reach people who were not connected to service providers. But we also got some recommendations from service providers on where we might find people or people that we might want to talk to in general. And we had some great assets. I know that you can't see them, but we started it off with a trauma-informed protocol for ethical engagement, a script that was guided by a trauma-informed framework. We had incentives to fairly compensate people for their time, and we had flexible and fixed supplies. So we had food, dog food, Narcan, condoms, and we also had a small discretionary budget to buy people the things they told us they most needed in that moment. So for example, we bought a phone cord for a person who needed to charge their phone to call their family, and we bought an ACE bandage for somebody who had a recent injury. And just trigger warning here, I'm going to talk about some hard things. So if you need to take care of yourself, take care of yourself. But I can't summarize everything that we heard during this assessment, but we heard some stuff like people could not apply for jobs or services because they had a repeated theft of their documentation. We heard about people who were transported to emergency departments during storms because there were no shelters for them to be in. We heard about a person who was experiencing violence in the community from the community who could not access a domestic violence shelter because it was not technically domestic violence. And we actually have some associates that helped us with a portion of this project who called that shelter and were told that the shelter would not serve the homeless. We heard about a gentleman who could no longer access senior services because they had an issue with him bringing his companion animal, and he didn't want to leave his companion animal alone. And we heard about a community where there were repeated fires in abandoned structures because people were trying to stay warm, and they were aware of that, but they were unwilling to fully fund a fully operational shelter because of stigma. So our initial intention with this project was for it primarily going towards funding and programmatic purposes. But unfortunately, when we started this project, over the course of it, the MHRDP lost funding. So We had to quickly pivot and figure out how is this still going to be meaningful. So now we generally want to highlight the needs and gaps in services in these selected areas. The shifting purpose shifted our timeline. This is no longer a rapid needs assessment. It's gone on a very long time. There was a rapid portion. So we learned some stuff like in these areas, there was a general lack of awareness among people and service providers of the MOUD services through the public health offices. So we took that information back to NM Health and back to the harm reduction team so that they could use that information to increase awareness in these communities. And we did that almost immediately through meetings, phone calls, emails. But the rest of this, we're taking a slower approach because now that we don't have a program to directly influence, how are these results going to make a difference? And we really wanted to include people with lived and living experience in the evaluation and the future program planning, but there's no program to plan anymore. So we're really shifting so that we can try to figure out how to include people in the data analysis process, the dissemination plan, and how to keep including them in the future. And then originally the scope of this assessment was supposed to be these 4 priority counties and then eventually expand it statewide with the help of our partners. But now the report will solely focus on these 4 counties. So some other messiness. It's a constant battle of us versus technology. It was very hard to get these recordings in windy conditions with people speaking softly, with cars in the background. We forgot gift cards one time and had to have somebody wait while we ran to the store to get a gift card to provide them with their incentive for kindly speaking with us. This picture is of us getting lost. I got us lost at Elephant Butte and had to do some moderate off-roading. Please don't tell the rental car company. Because we were trying to find a gentleman who was camping out there. And we did a lot of crying in the car. We heard some really heavy things, as much as you think that you can prepare and you have like a self-care plan. It's heavy stuff. But we had some really positive unintended consequences just from the process itself. We were able to spread awareness of MOUD in these communities in real time as we were out there. So if somebody told us, no, we don't know about that, we would give them flyers and we'd give them information, contact information about the MOUD service in the public health office, all the service providers, we gave them flyers to put up in their offices. We got a better understanding of how to communicate and reach folks in these places and distributed those resources, but also created some warm handoff connections. So my colleague Daniela actually facilitated someone who was interested in alcohol use treatment, but there was no treatment in that area, in that whole county. Coordinated for them to have transportation and an open bed when they were ready for it, and gave them the contact information for direct contact at that facility. We sat down with first responders in an incredibly stigmatizing conversation, which we turned into, and met them where they were at. And over the course of the conversation and being open and asking more questions while also tackling some misconceptions, by the end of that conversation, they were asking how else they could help. We initiated a conversation with a provider who realized the needs that they were identifying, they could actually tackle some of those right now. So they championed the installation of a bus stop in front of a treatment location, which already was installed. And then just in general, people were happy to be heard and involved. I feel like in research, if you are an ethical researcher, you're always aware that you don't want to oversample people, you don't want to question them to death. But sometimes this is the first time that somebody's actually heard someone and asked them in your own words, what is your story? In your own words, what do you need right now? So our next steps, we need to analyze what we actually collected, and we have some help. We have some medical students, medical residents at UNM who are helping us with some policy analysis. They also conducted a shelter analysis of which counties actually have none and which have entry requirements for shelters and that sort of thing. We want to work internally and with partners to identify ways that this data can help. We all know that there's reports out there. The Coalition to End Homelessness puts out a report every year. It states a lot of the stuff that I just stated, but how can what we did actually land somewhere and make a difference? which the Coalition to End Homelessness is doing amazing work, and their report definitely makes a difference. How can we add to that? How can we disseminate our data in ways that's meaningful and actually get it back to the people that we spoke with? And throughout the process, we started telling people, when we have this report ready, we're going to put it in these service provider locations. Keep an eye out for it. But we know that we have challenges with the current state of funding locally and nationally, and then also the political climate right now versus evidence-based interventions. But there's always a light at the end of the tunnel. We have networks of advocates and partners statewide who are doing incredible work, and people like you who are interested in learning, growing, and making a difference. So the main points are that you should be involving the people your programs will serve in your program planning and evaluation, at least in some capacity. If you don't know how to do that, in the resources, I have a great consumer engagement tool from the National Council on Healthcare for the Homeless. If your target population or your population of focus are people who are unsheltered. Otherwise, feel free to reach out to me if you have another population and you'd like some ideas on how to engage them. Don't leave people without resources, and be prepared not to cause further harm. I have some trauma-informed planning resources at the end. You can make an impact through data collection. Like, even if you are doing traditional research, please don't talk to people and be like, wow, that sounds really horrible, thanks, bye. Like, please, please leave them with what you can. Please do what you can to help them and connect them with things and leave them with the things that they need. And if you're not doing traditional research, don't be afraid to pivot or use that data reflexively in real time. And a big thank you and shout out to the people that spoke with us in the community, our community partners for making time for us and doing amazing work, Vital Strategies for funding our travel in this process, NM Health for using those results, and Authentic Evaluation for letting us speak. Thank you. And shout out to my husband because he drove up from Albuquerque.